Uh, we're going to talk about AOT in New York City, which is one of maybe the biggest AOT program. I just want to say at the outset that I'll be presenting data here from the New York City Health Department and the New York State Office of Mental Health, but any opinions I express are going to be purely my own and are not an official position of either agency. And I have no financial conflicts of interest. So, what we're going to talk about today, going to start with the structure of AOT in New York State, because after all, it is a state law. Um, we'll talk about AOT eligibility criteria, the AOT process specifically as it occurs in New York City, what happens during AOT in New York City. And then I want to share some descriptive statistics for our program, um, some outcome data, and talk a little bit about some of the complexities of administering an AOT program in this environment, and hopefully leave plenty of time for questions and comments. So AOT in New York is one of the older AOT programs authorized by Kendra's Law in 1999, which was enacted after the murder of Kendra Webdale and is named after her. The law has been renewed every 5 years. It's never been made permanent, but always enacted with a sunset clause because it remains a controversial program. In New York's AOT program, the judiciary is only involved at the time of granting or renewing an order. There are no repeated appearances before a judge. And the law gives the New York State Office of Mental Health overall authority over the program, but leaves its actual implementation to local governmental units. So to be eligible for AOT in New York, you have to be 18 years of age or older and diagnosed as mentally ill. A substance use disorder by itself does not qualify, and be unlikely to survive safely in the community without supervision, and unlikely to voluntarily participate with a treatment plan. Also, based on history and current behavior, you have to be in need of AOT in order to prevent relapse or deterioration that would likely result in serious harm to self or others, and you have to be likely to benefit from assisted outpatient treatment. In addition, you have to have a history of lack of engagement with treatment that has resulted in one of the two following things: either 2 episodes of treatment in a psychiatric inpatient unit or forensic or other mental health unit within the last 3 years, or 1 or more acts of serious violent behavior towards self or others, or threats or attempts at that, within the past 4 years. Now, again, just emphasizing this has to be in the context of a lack of engagement in treatment. There's, in addition, about a year or 2 ago, a third pathway was added in New York State for people who have been on AOT any time in the previous 6 months, and now after AOT are showing deterioration that interferes with major life functions. So what is the process involved? Well, first of all, an investigation involves gathering medical records to demonstrate that the person meets the criteria that I just went over. Obtaining records requires either consent or a subpoena. If the person is hospitalized, then the investigation's done by the hospital, and we at the health department review that. If the person's in the community, then we do the investigation at the health department. If the basic criteria appear to be met, Then an examination is done either by a hospital psychiatrist if the person's hospitalized, or a health department psychiatrist if the person's in the community, in the presence of a mental hygiene legal service attorney who represents the individual. A treatment plan is then developed and approved by us at the health department after we confirm that all the providers listed on that treatment plan are willing to commit to participate in it. There follows a court hearing, which is an adversarial proceeding with MHLS representing the respondent. Medical records are introduced into evidence to demonstrate that the person meets criteria, and the examining psychiatrist has to testify at the court hearing, and of course is subject to cross-examination. So at the end of that hearing, the application is either granted for what was requested, which can be a maximum of 12 months, modified, for instance, the court may shorten the duration, or denied by the court. Renewal of an AOT order requires a new examination and a new court hearing. So once a court order is granted, these are the provisions. It's a civil court order, completely unconnected with the criminal justice system for up to 12 months with an accompanying treatment plan. The key provision here is that it commits both the person under order and the named providers in the treatment plan to following that plan. And I often say that that second part, the making sure that the providers are doing what they committed to on the treatment plan, is as important as the aspect that applies to the individual. The actual law as written only requires care coordination at a minimum on the treatment plan, but treatment is almost always included, usually mobile treatment, for instance, ACT, or clinic treatment plus care coordination. And I'll talk a little later about the breakdown of that. Providers cannot close a person's case for the duration of the order, and providers must regularly search for the patient if they're missing. In New York City, the AOT office at the Department of Health monitors adherence of both providers and individuals under order through weekly electronic progress notes and monthly discussions with the providers. We also take reports of significant events, which you can think of as adverse incidents, and those are reportable immediately to our office by providers. Now, the only so-called teeth in AOT are that an individual can be involuntarily transported by the New York City Sheriff. And I have to tell you, before I joined this program, I didn't even know New York City had a sheriff, but they do, and that fairly large sheriff's office. And the person can be transported by the New York City Sheriff to an emergency room. Excuse me, that's called a removal. If either they're non-adherent along with evidence of a potential need for a hospitalization, or they're missing from treatment, either physically missing or not allowing regular assessment. Removal requires authorizations by 2 psychiatrists, and at least one of those has to be a Department of Health psychiatrist. So the criteria for removal are quite stringent. AOT does not permit removal for non-adherence without evidence of deterioration. So, in other words, someone can refuse their medication as long as they don't look like they're deteriorating to the point where they might need hospitalization, as long as they're allowing themselves to be assessed regularly, they are not subject to removal. AOT does not permit forcible medication in the community, which is one of the sort of major myths about it. And AOT removal does not guarantee admission, and we'll talk about those statistics a little later. All it does is guarantee removal to the emergency room, at which point the ER psychiatrist is going to make an admissions decision. So as the end of the order approaches, one of our psychiatrists will review the case, looking at the adherence during the AOT order, the clinical course, and significant events, especially hospitalizations, emergency department visits, and acts of violence or self-harm. One of our psychiatrists then examines the person in the presence of their MHLS attorney and recommends either a renewal of the order. If it seems like it's unlikely they'll voluntarily adhere to treatment without AOT and the order has been a benefit, allow the order to expire without renewal. And that's if the person's likely to voluntarily adhere to treatment, or if there's been a lack of benefit from treatment. Or they may offer the person what's called a voluntary agreement, which allows us to continue to monitor the case, but is not court ordered and does not give us that removal authority. If there's going to be a renewal of the order, then there has to be a new court hearing. So that's the basic outline of AOT. And let me tell you about our program specifically in New York. As I mentioned, we're a large program. As of May, we had 1,950 people in New York City under AOT. That's 54% of all the people in New York State who are under AOT. As you can see by the breakdown by boroughs, the Bronx has the most, Queens the least. About 10% of the folks on AOT are sheltered homeless and about 2% unsheltered homeless. If we look at the referral sources for AOT, then we see that our biggest referral source by far is hospitals, including city hospitals, voluntary hospitals, and state psychiatric centers, followed by referrals from the community and from state and city corrections. If we look at the racial and ethnic breakdown, we see that in general, the census of AOT mirrors the breakdown of the referrals we get. However, if you look at the referrals that we're getting, of course, there's a tremendous overrepresentation of Black individuals, which is, I believe, a reflection of both the implicit bias with which many hospitals and correctional institutions look at these situations, and the social determinants of mental health resulting from the structural racism that's baked into both our hospitalization and carceral systems. As you know, Black individuals are both hospitalized and incarcerated at rates way beyond white individuals, way beyond their representative numbers, either in the general population or the SMI population. So when we look at certain outcomes in AOT, when we look at deaths, when we look at removals, we always try to look at those through an equity lens and try to disaggregate data by race and ethnicity. If you look at the age breakdown, it's young to middle age, overwhelmingly male. Now, if we look at what's actually included on AOT court-ordered treatment plans, of course, they all have some form of care coordination. So about 60%, a little more than 60%, have some form of mobile treatment. And in New York, that can either be ACT, assertive community treatment, FACT, forensic assertive community treatment, which is ACT with a forensic specialty for people who've been involved in the criminal justice system, shelter program assertive community treatment, those are ACT teams associated with specific homeless shelters, intensive mobile treatment, which is another city program that is a little more intensive than ACT, and about 38% have care coordination with treatment, usually treatment from a clinic program. 99% of our active roster has some form of medication listed on their treatment plan, and 86% has long-acting intramuscular medication. How long do people stay on AOT? Generally 6 to 24 months, although there certainly are people who have been on for much longer. Now, during AOT, if we look at significant events, we see that 59% of people on AOT in the last fiscal year had significant events. Some of those can be relatively minor. Some of those can be major, like an arrest, loss of housing, hospitalization, or a violent act. 21% of consumers had a removal issued for a total of 829 removals. However, only 388%, or about a little less than half of those removals, were executed because often the individual is brought to the hospital by other means, such as 911, or can't be found. Now, of those 388 executed removals, only 60% actually resulted in admission to the hospital. 40% were treated and released. So what about the end result of AOT orders? So we tend to divide closures, or the end of a period of AOT, which may involve multiple orders, into three categories. Positive, which is in the judgment of our program, the person's no longer in need of AOT. Neutral, and the positive is about 40%. Neutral, those are things like the person moved out of New York State, or the court denied a renewal petition. And the largest category, about 50% negative, those include people who are deceased while on order, who've gone missing at the time that the order is expired, and so can't be seen for reevaluation for a renewed order, are hospitalized or incarcerated at the time of the end of the order. If we look back at the about 2,600 folks who went through AOT in 2024, 34% had previously been on AOT, so about 2/3 were new to AOT. Now, what about the effectiveness of AOT? So this is data from the New York State Office of Mental Health, but specific for New York City. And it compares a particular experience of an event either prior to AOT or at any time while on AOT. So we see for hospitalization, 96% of the people on AOT had experienced hospitalization prior. That makes sense. It's baked into the criteria. And while on AOT, 36%, so a marked decrease. Incarceration, 26% prior to AOT, 8% at any time while on AOT. So I think these are probably some of the most powerful statistics for looking at effectiveness. If we look at service utilization, then prior to AOT, 25% taking medication. That makes sense, again, because of the way AOT is set up. At most recent follow-up while on AOT, 80% taking medication. Use of substance use services, 10% prior, up to 40% during, or at the most recent follow-up, I should say. And so I just want to mention and then we can go to questions and comments, um, some of the complexities of a program like AOT in New York City. Probably the biggest complexity is we're considered by the state to be one local governmental unit and therefore administering one AOT programs. But New York City is 5 counties with 5 separate court systems, 5 separate legal offices representing individuals in AOT proceedings. And New York City is a place where people are quite mobile, moving from one borough to another very easily. So you can see that moving from one borough to another, moving from therefore from one court system to another, vastly complicates administering AOT in New York City, and is the reason that our office is divided into borough teams. I should also mention each court's a little different in their characteristics. Each MHLS office is a little different. And to be effective in a particular borough, one has to adapt to the quirks of that particular borough's legal system. Another issue is that even though New York City, compared to many other places, has a very rich service environment, there's still a very substantial waiting list, particularly for mobile treatment. And although AOT gets someone priority, there can still be a wait. If there's no slot available, there's no slot available. So there can still be a wait. In addition, in any one year, we're tracking thousands of individuals being served by hundreds of providers. So that presents an enormous challenge. We therefore have a large number of staff. We have very detailed policies and procedures because you can't wing it when you're tracking a system that complicated. And we use an electronic portal, both for our own data and the data we receive from providers. Another complication in New York State is something known as the Miguel M decision. This was a decision by the New York State Court of Appeals that required either subpoena or a consent for us to obtain the medical records to conduct an AOT investigation. And as you might imagine, there are many people who are not going to give consent for them to be investigated for AOT. And obtaining a subpoena can involve a complex series of court appearances. This has particularly had a big impact in community referrals and referrals from city jails, because people, in the time it takes to obtain these records, people can disappear off the radar, people have unexpected release from jails. And so while we generally are able to turn about 85–90% of the referrals from hospitals into AOT orders, that number goes down to about 50% for community referrals and less for referrals from the city jail. From state corrections, the numbers are very high because they obtain the order before the person leaves prison. In addition, it takes much longer, again, because of this and other issues, for a community referral to become an AOT order. And then one last issue I want to just point out is we see a tremendous underuse of medication-assisted treatment for those who have co-occurring either opioid or alcohol use disorders for which there is effective medication-assisted treatment. We looked at folks who were referred with a co-occurring diagnosis of either opioid or alcohol use disorders, and only 13% of those had relevant MAT on their treatment plan. So we're really gearing up to try to improve that aspect of AOT treatment. And that's it. I'd be happy to take any questions or comments. We're virtual, so you can't throw vegetables, but happy to take questions or comments.
Thank you so much, Dr. Fisher. I can start. I'll just look in the Q&A for questions that were submitted first, and then we'll go on through. So Christy Doyle asks, how are updates and modifications to the plan dealt with in court? Hopefully things will change as clients improve.
Yes, and that's a great question. We try to make the plans flexible by including what we call contingencies. So we might have certain medication on the treatment plan, but then there's a series of alternative contingency medications if the psychiatrist and the individual agree that this other medication is working better and is more tolerable, then they can be changed and still be within the treatment plan. Also, if someone changes from, say, one clinic to another clinic because they moved, or one ACT team to another ACT team, that's considered the same level of service and doesn't require us to go back to court. It's not considered what's called a material change. So in general, we're able to be pretty flexible, and within the course of a single AOT order, major changes then would be made at renewal time in the new treatment plan for the renewal order, and that of course would go back to court. I'm sorry, I can't hear
You're
you.
muted. I was
Yeah.
muted. I was just saying, if we answer a question and it prompts another question, feel free to keep submitting questions, everybody, as well. Thank you so much. Janet Hayes asks, what holds the provider accountable to not just discharging the client? Does the health department contract with the providers?
We don't contract. Well, we contract with some of the providers. We're contracted with most of the city's ACT teams. In terms of the clinics, we work very closely with the Office of Mental Health that licenses them to make sure that they're held by their licensing authority to that commitment. And for care coordination, again, if we don't have a license with the particular organization, we'll work with their licensing authority to make sure that and our providers are pretty well educated in New York. They understand that, you know, what they have committed to when they take someone on AOT.
Thank you. Our next question, I see we have a lot of questions, so I'm just gonna
Good.
keep firing them right at you.
Great.
Bill Neiman asks, is there a statutory or regulatory basis for the voluntary agreement option for continuing monitoring without removal authority, or is that purely an administrative program within New York City?
It's administrative within New York State, and it's called, some please call it an enhanced service agreement. And what it is essentially a contract that's largely a consent a release of information for us to continue to be in touch with the person's provider. Um, there's, of course, it's can be revoked by either party at any time. Usually has either a 6 month or a 1 year term, but the individual can certainly revoke it at will, like any other consent.
You. Another question from Christy Doyle. She asks, does FACT include restoration services along with the usual ACT service array?
No, I assume you mean restoration to competency. Uh,
I would assume so, but if not,
um,
Christy,
yes,
would
no,
you like
that's a
that?
completely separate process in New York.
That's good.
I would like to go ahead and there's our friend Brian asks that
Uh-oh. Hey, Brian.
New York City recently reported a 10% year-on-year increase in active AOT cases. And I will say that that's not only in New York City where that's happening. So I'm curious about your answer as well. What factors are driving the increased caseload, do you think?
I think that,
But there's
and
more, because it's Brian, there's more. And do you view the increase as an encouraging development?
um, a couple of things. I think one thing we're seeing is that last year, that previous year, 2023 or fiscal 2023, we saw a big rebound from the dysfunction of the system during COVID. And a lot of those folks remained on AOT into fiscal 2024. In addition, we are getting our usual robust numbers of referrals. So the main reason we have more people served in 2024 is the essentially the holdover, which is probably a good thing, of those people from the previous year remaining on AOT, while uh, the same goodly number of referrals came in uh, as had the previous year. Is as long as appropriate people, I'm less concerned with the numbers than with people who can benefit from AOT and for whom it's the least restrictive alternative being served by it. So I have confidence that, the people being put on AOT are appropriate. I think that um, that's a good thing. Ideally, in an ideal service environment, we would need less AOT, because we'd have services that engage people without such a focus on a medical model of care. But so my own feeling and the official position of the health department is that we are neutral on whether an increase is a good thing or not. As long as we're getting the appropriate people for whom we can do good on AOT, that's the important thing. So sorry if I'm kind of dodging the question, but uh, um,
And I'm gonna just jump in real quick. I saw a question there from someone who is heading an AOT program in Georgia, and she mentions that they use probate slash committal orders to state psychiatric hospitals in addition to involuntary hospitalizations to ERs. And she mentions that with the ER, they struggle to get them to stabilize people and instead will discharge them within a day of completing an involuntary order, despite reports from the community mental health clinic staff and family. And so she's asking, how important is it to have a good relationship with the ER?
It's tremendously important, but you can imagine in a place like New York City, there are so many ERs with so much staff turnover that uh, we always try to advocate, excuse me, when we think admission is indicated. But in the end, as I pointed out earlier, only about 60% of those who are removed through AOT to ERs get admitted. Now, some of that is perfectly appropriate. I mean, the person, may just need the opportunity to get their long-acting intramuscular injection, which they've been refusing in the community or something like that. But we think there are a number of people who could benefit from admission who probably don't get admitted, and we're constantly trying to work with ERs. New York has a program called CPEPs, Comprehensive Psychiatric Emergency Programs, which can hold people longer, give more thorough psychiatric evaluations, and when possible, we try to see that the removal brings the person to a CPEP rather than a regular psych ER. But I totally sympathize. We have exactly the same issue in New York City.
And this may not be under your purview, Dr. Fisher, but I'm thinking just for the person who asked the questions purposes, do you have any tips for improving those relationships?
I think it's really a matter of outreach, both on the individual level and if your hospitals are organized in a state, a city or state hospital association, something like that, reaching out on that association level too. It is very difficult. The other thing that can be useful is in New York State, we have a system run by the Office of Mental Health called Psyches, for which essentially uses Medicaid claims and other data to provide a 5-year psychiatric history of every service somebody's been given, every diagnosis they've been given, and the CPEPs can check that and see if in fact a person is uh, is in a repeating cycle. And absolutely, the clinic and the AOT program itself should be talking to the ER when the person is brought there, as soon as they become aware, to advocate for what they think is the most appropriate disposition. It may not happen, but it's worth trying.
Thank you.
I'm having trouble hearing you. I'm sorry. Sarah, you're maybe either muted or something.
It might be the internet.
Can you maybe, Sarah, put it in the chat?
I can throw you another question, Dr.
Okay.
Fisher, while she's putting that in the chat. I'm gonna actually switch to the chat, and Mac is asking, you said that a person must be considered able or likely to benefit from AOT. Can you say more about that and how it's determined?
Sure. This becomes more of an issue at renewal time than in the initial AOT order. In the initial order, you're hypothesizing essentially that they'll benefit. But now when you come to renewal, you have a track record. So let's say, despite the order, the person never engaged in treatment. They were repeatedly removed to the hospital by EMS before even an AOT removal order could be issued. So, and they never let the ACT team or whoever in the treatment plan see them. Well, that person's really not getting any benefit. The AOT is not encouraging treatment for that person, and it's not serving as a safety net to remove them to the hospital because they get removed quickly by other means. So where is the benefit? Those cases are rare. Usually AOT is of some benefit to the person because we're pretty good at this point in figuring out who is likely to benefit from AOT, even if it's reducing the number of hospitalizations, maybe not eliminating them, reducing the number of significant events, things like that.
I think that makes a lot of sense, Dr. Fisher, and seems consistent with other things that we've heard from other programs as well. I did want to say quickly that I saw a couple of questions in the chat and the Q&A that were asking about relating to using some of New York's data for their advocacy in other states. So I'm going to put a link in the chat to a bunch of dashboards with publicly available data from some.
OMH has a terrific set of data available publicly on the AOT program. That's great, Shanti, because
I highly recommend everybody checking that out. It's one of the best and one of the only publicly available dashboards with AOT related data. And I also wanted to throw you another question just because this is in some of our support that we've provided to other programs. A question that's come up a few times is relating to the relationships between law enforcement and the AOT program. And so this question in the Q&A asked, are there alternatives to conducting removals? I'm guessing that would include pickup orders that don't involve law enforcement. And they noted hoping New York City can move toward a more therapeutic approach for our clients, especially for folks who have a negative response to law enforcement. Curious about your thoughts on that.
New York City is moving in that direction a bit with its Be Heard program and other programs that combine mental health practitioners. Some programs are peer forward, but in terms of someone who is not complying with an AOT order, looks like they need to be in the hospital. Once that removal is issued, it is always executed in conjunction with law enforcement. Now, there are times we are able to send clinicians out with law enforcement, but one reason we use the sheriff instead of NYPD is they have more experience with this, and it's a little bit less traumatic, but it is always a traumatic experience, obviously, to be brought anywhere against your will, and especially to an ER, and especially if you have a negative view of the mental health system. So, I think there is a general movement, which maybe AOT can be part of at some point, to be more peer forward, even in the more coercive aspects of the program.
Yeah, and I think that can hopefully provide a good answer and some strategies for the person who asked that question in terms of who to reach out to, what to look for, and of course, noting that being taken anywhere against your will or in handcuffs is always going to be a difficult and trauma-inducing experience, as much as we would like to provide alternatives.
One encouraging thing is that more and more ACT teams and mobile crisis teams have peer staff on them, which is helpful.
Absolutely. And hopefully is another recommendation that people can kind of take with them to their work as well. Let's see. We still have so many questions. Thank you so much, everybody, for all of the wonderful questions. We will keep going or until we don't.
That's fine with me. We can keep going till everyone's question has been addressed.
Let's see. The oldest question in the Q&A right now. So this is a question. It's asking about the assessment that is made about whether or not an individual is likely to continue in treatment. And so this person is asking for AOT cases that are closed because the patient is judged as likely to continue in treatment without monitoring. How often do you see those individuals returning to AOT later down the line?
So if we looked at the folks who went through AOT, who came on to AOT in 2024, about a third of them had previously been on AOT. Now, I don't have the division of that into positive and negative closures. So a lot of them may just have disappeared and therefore were closed. But so I can't give you a statistical answer, but my guess is it's significantly less than 30%.
Great, thank you. Apologies for the delay while I scroll through questions. Let's see. See one question this is from Kelly, both in the chat and in the Q&A, asking about anosognosia or lack of insight. And they would like to know, how often do you see that as a factor in AOT participants, and is it handled in a specific way? Are there strategies or things like that for participants who also lack insight into their illness?
We don't specifically assess anosognosia in screening for AOT because there may be many reasons why someone may feel that a label they've been given as having a mental illness or they're having been hospitalized is uh, is false or untrue. So to us, whether we believe there's a neurological basis or a social determinant basis or a traumatic basis doesn't matter so much as that the person doesn't recognize their need for treatment, and that's gotten them hospitalized multiple times or into other kinds of difficulty.
A similar question, I think, to the question about insight was Melissa was wondering, she said, what is the percentage of TBI? I'm guessing traumatic brain injury. And also, are you able to obtain medical records from the DoD, which I'm guessing means the Department of Defense?
Yeah, it's the whole interaction with both the DoD and the VA system is very fraught for AOT because it operates under state law to which neither the DoD or the VA is beholden. So things like the ability to monitor a person if they're getting their treatment at the VA, unless the VA will not accept the court order as a reason to share information with us. It requires a consent, which the individual can withhold or not. TBI, standalone TBI would not be a qualifying reason for AOT, but it's certainly the case that many people with other mental illnesses have accompanying TBI, either of military origin or a community origin, and it's very hard to find appropriate services for those individuals.
Absolutely. Let's see, more questions. Here's a question from Zachary. And I know that in New York City, the forensic system and AOT are somewhat separate.
Right line separate.
Got it. Well, I will ask. I'll go ahead and
Go ahead.
and then we can always move
Yeah.
on if it's a quick answer. But Zachary was wondering if the AOT in the five boroughs is ever used as a step down from hospitalization or for continued engagement during that discharge transition or from forensic programs like competency restoration. And also, what is your experience in working with DAs to divert?
So often, actually, it's the defense attorney who will try to get a person onto AOT as a way of convincing the judge to release them, either pre-trial or post-trial. But it's completely separate from the state's official alternative to incarceration programs, which are structured very differently, involve repeated appearances before a judge. Um, and so sometimes incidentally, those people will be on AOT. But again, when that happens, it is incidental. And we in general don't think it's a useful use of our resources, because if a person has an ATI, it's a duplication of services. The way restoration works in New York, for the most part, is felony restoration is almost always done inpatient at specialized forensic state psychiatric centers. And for most misdemeanors, restoration is not required because the charges are then the person's moved to the hospital and the charges are dismissed. So not a big role in restoration. In terms of hospital discharge, absolutely. Hospitals are our biggest customers. And, to help someone move from the structure of the hospital to the relative lack of structure of the community, an AOT treatment plan, if they meet criteria, can be really helpful.
Yeah, absolutely. And we definitely also believe that AOT can be an extremely valuable tool in the discharge planning toolbox. But I guess also for Zachary and for anybody else who was wondering about using AOT for that kind of transition forensic population, there was a recent study that came out on the last cohort of SAMHSA grantees that found AOT was effective for step up from the community, step down from the hospital, and also for people who are involved in the criminal legal system. So if your program is interested in doing that, it definitely is still feasible.
We have a substantial number of uh, people on AOT upon release from state prison who finished hit their maximum dates of incarceration or on parole, and the prison mental health service then obtains an AOT order before they're released. We also have people pre-trial referred by the jail on AOT. So absolutely, it can be very helpful. I just sort of want to make it clear that it's not an official part of any alternative to incarceration program.
Absolutely. And I think is an important clarification as well. Um, I saw someone in the chat asking for the link for the study I mentioned, so I will go grab that. In the meantime, Brooke, would you mind taking over moderating questions? Thank you.
You're muted, Brooke.
Thank you. Thanks. So I'm going to jump around a little bit here, but so Connie is asking how quickly you guys in New York City are able to get someone on an AOT order when they are in the hospital and determined to meet criteria.
If everything goes well, then, as little as 2-3 weeks, probably on the average closer to 4 or more weeks, which is why it's really important for hospitals to think about AOT not the day before discharge, but on the day of admission as part of discharge planning. That gives time to obtain the order while the person's in the hospital.
Thank you.
I
Oh,
have
go
a
ahead, Amy.
question. You use outside evaluators to determine whether to ask for a continuation of the order. And a lot of programs use the treatment team and the psychiatrist treating, and I mean nationally. They do not use independent evaluators. Do you see a benefit of using independent evaluators, or is that just the way it's set up? Or
I do see a benefit. Obviously, of course, we're in touch closely with the treatment team about their opinions on the matter, but I think it can put the treatment provider in a very difficult position in terms of alliance to be also the evaluator of whether a court order should continue or not. Not to mention our New York treatment providers are pretty feisty, and I can't imagine many of them agreeing to do it. But so, yeah. Also, I think you may be a treatment provider who's only worked with a handful of folks on AOT. Our Department of Health AOT psychiatrists have worked with hundreds and hundreds of folks on AOT and really can provide a more expert evaluation.
thank you.
Sure.
And for everyone who asks questions, I apologize for going out of order. So I don't believe we've addressed this one yet. Sonia is asking, how hard is it to find a bed in New York City? And how is there a bed available for everyone who needs it?
It's pretty hard to find a bed. There's pressure in ERs to not admit people often. I would say New York is more richly bedded than most states, but it still doesn't meet the need.
I think one of the interesting questions that was asked was you mentioned in your talk that there would be a reduced need for AOT if we had a more service-rich treatment continuum for this population. What kind of services are you talking about?
So, for instance, we've two things I'll mention. One is what we call intensive mobile teams here in the city that work with people largely who are either homeless or unstably housed, often have a history of aggressive behavior, may have confusing diagnostic picture, and they have a very good, staff to patient ratio, much better than an ACT team, and spend essentially as much time as is needed to begin to engage the person around issues that they can agree on. The other thing is there's been a big push in the city to increase the number of clubhouses. And clubhouse programs, again, can be a place to meet someone who may not be thrilled about a medical model approach to their illness, to meet them where they are. So again, I think the more flexibility we have to meet people where they are, there'll always be a group for whom that's not going to work. But I do think the more tools that we have.
Thank you. Let's see. So where was I in the questions? Aha. Okay. So Bill is asking again, or asking about whether or not in New York City, the administration allows patients, caregivers, and current providers to participate in the development of the treatment plan, or if the treatment plan is designed, I guess, solely by the county.
The current providers, if there are any, are absolutely involved, and so is the person, because again, they may have had a much better experience with one type of thing versus another thing, both of which were equally effective. Let's take medication, for example. There's no reason not to take that opinion into consideration in developing uh, a treatment plan. Also, in developing a renewal treatment plan, what's been their experience, what parts of how has treatment been for them, and what's been hard, what's been easier, is really important.
That's great. Thank you.
Yeah.
I can jump in with another question because I think I accidentally marked this one as answered and they submitted it again. So I want to make sure they get their answer. This is from Jane. So I know we talked a little bit with about the Department of Defense, how it can be difficult to coordinate between these federal programs and AOT being a state level statute. But Jane asked, why doesn't the VA work with AOT when veterans are in mental health courts after many hospitalizations and jails? Such as she gives an example of a VA veteran with schizoaffective disorder and mentions that judges have said that the VA does not recognize AOT.
What the VA doesn't recognize is that the court order is in any way binding on. Remember, I said at the beginning, it's just as important that the provider, we're we're compelling both the person and the provider to work with each other. The VA does not recognize that the force of that order, even to the point of not sharing information about the person under order with us, um, unless the person signs a separate consent to do that. So that's why we have worked with the VA on occasion. It's been a bit rocky because we can't do that important piece of AOT with them, which is unfortunate because there are a lot of veterans, I think, who would probably benefit, and the VA doesn't have anything sort of similar that they can do for veterans. So
I will say that there are a very few jurisdictions that have been able to work with their local VA, but it is the red tape and getting records and business associate agreements established with the VA is there are so many barriers, and kudos to those few jurisdictions that make it work.
that's great that there are at least some that have done it.
Yeah, I know Janet in the chat mentioned that their VA works with their AOT program. So Janet, if you wanted to type anything up for others who might be interested in how you guys got that partnership going, absolutely feel free to do that. In the meantime, Sonia wanted to make sure we had a chance to ask her question, which was, and thank you for waiting, Sonia. I see that you submitted your question a while ago. And thank you everybody for staying on, and especially you, Dr. Fisher.
That's okay.
So, Sonia's question was, for those who cannot participate and need a higher level of care than AOT, what is the protocol? Or are they left to the streets or inappropriate settings and we just wait for an arrestable offense and hopefully not a victim?
Well, since the purpose of AOT is to provide to allow someone who would otherwise be hospitalized to survive safely in the community, we don't really have a more restrictive outpatient uh, intervention. Um, I think maybe you're referring to people who don't sort of meet the technical criteria, um, but clearly are not going to voluntarily participate in treatment. We don't have an answer for that. They have to meet the criteria spelled out in the law to be on AOT. And often for those people, that's their best chance of not, being in the hospital either repeatedly or long term. I'm seeing the chat, a higher level of care. Well, the AOT is not a level of care. The AOT treatment plan mandates a level of care. ACT and IMT are the highest community-based levels of care that we have. We have nothing higher than that short of hospitalization, unless I'm misunderstanding the question.
Yeah, Sonia, feel free to post again in the chat if further clarification would be helpful. We're definitely happy to answer. I'm gonna go back to some of the others who have been waiting a long time to have their questions answered. So this is from Sharon, who said that she needed to jump off but might still be on. So she said that the data indicates that in 2024, 41% of people who had AOT were no longer in need of AOT. From the data of previous years, is there data about the longevity of positive effect? So it looks like it might be kind of a two-part question, one about people who are on AOT who may be ready for their court order to end, and another question about gains sustained past the end of the order.
So we did a study, it's a while ago, back in 2015, where we looked at for people who were what we call positively discharged from AOT, no longer in need. We looked at the year before AOT, the last year of AOT, and the year following AOT. And we showed that the gains in terms of reduced hospitalization, particularly, were maintained for that year following the end of AOT. We don't have any data beyond that 1 year follow-up that I'm aware of.
Thank you. Oh, Sonia posted another in the chat. She noted that's correct. And she said, I am just trying to be sure we account for people who need something between hospital and community level care. Many people are considered baseline. They are no longer meeting criteria for the hospitals as they aren't deemed to be able to benefit from treatment. Yeah, Sonia, I think for people who are at high risk or clearly experiencing some deterioration but do not meet criteria yet, that can leave individuals and families in a really difficult spot. But at least for the purposes of this talk, I hope that the answers that you've gotten so far made sense in regards to levels of care that might be available. But if you are asking on behalf of a loved one or someone you know, definitely feel free to reach out to our helpline and they may be able to connect you with some other services or options that could be helpful. Yeah.
Or 988
988
also.
is an excellent resource.
Yeah.
Absolutely. Yeah.
Another question is do you all use contingency management at all?
It's really hard to get any of our outpatient providers to do contingency management, even though there's been studies that show, particularly in the area of substance use disorders, that it can be particularly effective. So no, we haven't used it within the AOT program. We don't have it as part of an AOT treatment plan.
I'm going to jump in with our colleague Betsy's question. And she is asking, do you believe that AOT in New York City would be more effective if judges were more actively involved?
A really good question. That's the black robe effect question. And I don't know the answer. Maybe you guys, since you look at things at a national level, might know if there are places where that is done. That we do that in New York for alternatives to incarceration in the criminal legal system, but not for AOT. But I'm curious myself. If someone had to appear, say, every 2-3 months before the judge with a report on progress, whether that would make a difference or not, I don't know.
And I think that is the $100,000 question. We'd all really like some data that shows one way or the other. I will say, having experienced hearings in Queens a couple of years ago, I would not want that judge trying to be motivational at all.
I know exactly the judge you're referring to. He is, thank heavens, retired now.
Good.
I'm gonna ask Colleen's question, which is in co-occurring disorders, including SUD, does the low rate of MAT use you mentioned arise in any way from the low starting dosage limits, which could cause precipitated withdrawal, or is this more of a provider issue?
I think it's more of a provider issue because usually either the individual's usually coming out of a hospital stay, at which point they, are no longer, they have been through withdrawal, hopefully managed withdrawal. That is, I think it's just providers are really uncomfortable. They don't learn it. Psychiatrists don't really learn to get comfortable with these both buprenorphine and naltrexone. So.
More questions in the Q&A. So we're digging out our
Yeah.
whole questions slowly but surely. The oldest question is from Kristen, who asked, what is the process of getting a subpoena for records? Do you have to demonstrate that the individual lacks capacity to consent or decline to consent first?
You have to demonstrate, yes, that they declined to consent. Capacity is generally assumed, that they declined to consent, and that there is some likely reason to believe that, the person might qualify for AOT, and that they can contest that. And that can often involve more than one hearing. So it is an arduous process, but we do it when we need to.
The next question is one that you touched on a little bit in your presentation, but you might have more thoughts on, which was, can you talk about if there are racial or other biases at play with AOT? For example, who is determined to need AOT, the services received by people on AOT, and whether people are able to access voluntary services prior to AOT, etc.
I believe there are. I'm a little bit reassured that our AOT census is more or less a reflection, when we disaggregate by race, of who is being referred to us by hospitals and other things. But those systems are so inherently racially skewed, that, yes, I think there's probably significant bias at work there. That said, all the people for whom we get an order, I do believe meet all the AOT criteria, but they're probably similar people who of a different race, who are similar behaviors, who are not being referred for AOT. We do see, for instance, we looked at there's a bit of an excess in terms of removals, in terms of uh, um, uh, Black AOT recipients being overrepresented. So I've been working with our staff to when a provider calls asking for removal, to get away from language like aggressive or threatening, or and to tell us behaviorally exactly what happened, because the same behavior from a white woman that might be described as in some way annoying or angry is going to be described as threatening and aggressive coming from a Black man. So the more we can limit the scope of implicit bias, the better we can do in that respect.
I absolutely agree, and I think can also be when talking about anybody who has experiences symptoms of psychosis, moving away from sort of trait-based language to describing behaviors can be really helpful for reducing all types of stigma and implicit bias.
Yeah.
Absolutely. Um, Last question in the Q&A. Wow, we made it. Um, I know. Thank you so much, Dr. Fisher. You've
Sure.
been doing a marathon of questions here, and I know from the fact that we still have almost 60 participants in this webinar, everybody is just, we're soaking in your knowledge, and we're so grateful to have you here. Um, Question from Bill is the entry criterion of serious harm to self or others is a high bar for entry. How do you feel about a criteria specifying inability to provide for one's basic needs as a result of untreated SMI?
Well, the it's a little uh, tangential to this, but New York State over a year ago issued an interpretation of the involuntary hospitalization laws, which made it clear that danger to self does not just mean someone being acutely suicidal. Self-neglect to the point of being unable to care for your basic needs equally qualifies. So I think an argument uh, could be made uh, on that criteria. Although those people also often meet the two hospitalization criteria, so it's not necessary to go there. But that's the general trend in interpretation of danger to self has been to broaden it.
And we do have one last question that slipped in. But Colleen is asking if you feel that Medicaid versus private insurers have a different effect on AOT eligibility.
Not in New York because, well, it's funny because the vast there are not too many private insurers that are going to pay for you to have an ACT team. So what ends up happening is we often treat those people as if they were uninsured, which ACT teams are supposed to take a certain number of uninsured folks in New York. So yes, I mean, theoretically, private insurance often doesn't pay for the services that these folks need, but we will work to get them those services as if they were uninsured.
Thank you. Well, I think, oh, one more. Sorry. Um, Christy is asking, do you anticipate the changes to Medicaid and the inmate exclusion increasing uptake of AOT as a transitional service?
I we are pretty much, even though the vast majority of the folks on AOT in New York City are on Medicaid, we're reimbursement agnostic. So whether someone is coming out of incarceration with their Medicaid intact or not really won't make a difference in the services we find them in AOT.
Thank you. That's great. Well, I'm gonna call it. No more questions, everybody.
Well, I just want to thank you for having me and say it's been a real pleasure talking with everybody.
Thank you so much. And to those of you still on, we will share the recording with you as well as the slides.
Yes,
And
I
yes,
will get you, Brooke, the slides as soon as I can turn them into a PDF.
no worries. Take your time.
Okay.
Thank you again. This was amazing.
My pleasure. Thank you for having me.
And you're getting many thanks in the chat as well.
Oh, it warms my heart. Thank you.
All right.
Okay.
Well,
Bye-bye, everybody.
bye.